I wasn't prepared for this, and we're running behind and need to hear from Dr. Kocher. So he's come to talk to us. He has won every award and has held every position in the world of pediatric sports. I'll just relate you my memory of him, which is we all knew he was going to be a star even when he was a resident. Some people are just built for success, and Dr. Kocher has proven that. So I'll give it over to you.
Thank you, Mohammed. So I'm going to talk about ACL injuries in children and adolescents, getting to PLUTO. That'll become clearer at the end. My disclosures are shown here. There's no specific conflicts with this talk. It is a real treat for me to be here at UCSF because there's so many friends here, and I'm really honored to be here and to connect to so many people. Tad was a resident when I was a medical student at Duke, and has been a role model in many ways my whole career. Sig Bervin and I were residents together the same year, and thank God there's no social media, and so I can't tell you anything. Mohammed and Ainur were fellows when I was chief resident and fellow, and Colleen and Kristen were residents in our program, and I've worked so much with Colleen and Posna. Dr. Luke was one of our medical sports medicine doctors. Nirav and Sanjeev, my Indian brothers from other mothers, have worked so much in pediatric sports, and Sanjeev has really connected me back to India through POSI. And so it's a real treat to be back here. I was telling the residents yesterday that a career in orthopedic surgery is amazing because you get to do great clinical care and research and education, but you really realize it's about, these relationships that you form and friendships. And it's just amazing to have friends all over the country and all over the world at all stages of your life. And so it's great to be here. And it was great to get to know the UCSF residents who are just tremendous, and a great dinner last night. So thank you very much for that. And just lots of interesting facts, like Kelly, who we connected with Dartmouth in North Carolina, can juggle, is on a unicycle. Someone almost got hit by lightning. I forget who that was. And then, what was the third fact I thought? Oh, Leah, I took care of when she was 11 years old for a meniscus tear. So that was very interesting as well. So anyway, it's great to be here, and thank you for the honor. We're going to talk about ACL injuries in children, and this is a subject that's gained increased attention. And in the lay press as well. This was the front page of the New York Times. Big time injury striking little players' knees. This was a patient of ours. Front page of the Chicago Tribune. Another one of our patients, career-ending injury at age 11. This was the San Francisco Chronicle right here. Growing pains, children's sports injuries are getting worse. This was the ABC World News with Diane Sawyer. This was a patient of ours who tore their ACL from Maine and had surgery, and then he got to meet Tom Brady. So this drove a lot of ACL injuries in New England until Tom Brady left. But when we look at it epidemiologically, the numbers are impressive. And so we are seeing more pediatric ACL injuries. The first on the left is data from Emily Dodwell and HSS using New York State insurance data. I'm showing the threefold increase from 1990 to 2009. On the right are data from FIST, the pediatric hospital systems in the United States, that we published, showing a fivefold increase in all ages from 2004 to 2014. This is being seen internationally as well. So we see data from Australia showing a 2.5-fold increase from 2000 to 2015. And from the Scandinavian registry, it's the largest group of ACL reconstructions are in this 11 to 20-year-old age group. The literature as well is exploding. So you can see the number of articles from a PubMed search on ACL in children has really increased since 2000. And so we know the injuries are happening more frequently. They're getting more attention. Why is it? I think part of it is that youth sports has really had a paradigm change. As you know, kids have less free play. They're playing at greater intensities, higher competitive levels, early sports specialization. lots of involvement in with adults, and it's a large industry. So the youth sports industry is estimated to be over 19 billion, and that's just direct costs, not indirect costs of travel, et cetera. And so this is a big industry. And the numbers are quite impressive. And so over 3.5 million children, if we just think of 14 and younger, are receiving medical treatment for sports injuries every year. I think when these stories come out, and we've done some stories, with different organizations, they tend to turn very negative about youth sports, early specialization, and injuries. And some of them, some of these things are negative, but I think it's important to remember the benefits of youth exercise. So medically, lower rates of obesity, diabetes, better cardiovascular and bone health, and probably even more importantly, psychosocial benefits of youth sports. And so greater self-esteem, lower rates of teen pregnancy, drug use, greater career success. We've worked with Project Play at the Aspen Institute on this concept of a virtuous loop where physically active children are less likely to be obese, better test scores, less risky behavior, more likely to go to college, lower levels of depression, higher self-esteem, greater earnings, lower healthcare costs, better adult health, and then they're more likely to then have children who are active as well. And so this is sort of the goal and the reason we want to keep kids in youth sports and youth activities. And injuries are certainly part of this, but there are other parts that are sort of outside, the medical system as well, issues around cost and equity and recreational spaces, casual play, training of adults. And so all of these factors, I think, come to play when we look at this issue from a more societal perspective. So in this talk, we'll talk a little bit about non-operative treatment, what the surgical treatment options are, the issue of growth disturbance. I'll give you our treatment algorithm and then give you some thoughts in conclusion, again, leading to PLUTO. There is controversy about management of the pediatric ACL. There's controversy about the initial management. Should it be non-operative or should it be operative? What the risks are in terms of complications, growth disturbance, which techniques we should use, and how graft choices and maturity plays into this decision-making. We had an IOC consensus meeting on the pediatric ACL in 2017 in Switzerland. And like many consensus meetings, we left realizing we need more and better high-quality data to answer some of these questions. And this is a big impetus into our PLUTO study. So let's start with non-operative treatment. So this is a decision point when you have a skeletally immature patient with an ACL tear. Do you treat them non-operatively or operatively? And non-operative treatment would be, physical therapy, activity restriction, and then doing ACL surgery when they're older. And the advantages are you're avoiding surgery. The disadvantage is you have an unstable knee and you're at risk for meniscal chondral injury. It's hard to keep young active kids and families out of sports and activities psychosocially. And so these are some of the challenges. We looked at this with partial tears. So I think we do see partial tears of the ACL more in children than we do in adults. This was a prospective cohort study of 45 patients with arthroscopically documented partial tears treated without ACL reconstruction. And then we followed them forward to see who went on to need an ACL reconstruction. And about 30% of the patients went on to need a reconstruction. When we did Kaplan-Meier survivorship to look at factors, we found that the older kids did less well, the 15 to 18-year-olds. We found that the extent of the tear was important. So those tears that were over 50% of the width of the ACL did less well, and the location of the tears. So those tears predominantly involving the posterolateral bundle did less well than those tears involving the anteromedial bundle. So this is all for partial tears. What about complete tears? There's been a number of case series, including some studies that we did, that all show very similar findings, that there are high rates of meniscal tears and chondral injuries if you treat these injuries non-surgically. And if we look at some of the data, the Todd Lawrence study from CHOP, greater delay over 12 weeks, increased incidence of tears and chondral injuries. Alan Anderson's study over 12 weeks, the odd ratio was almost 3 in terms of meniscal tearing. And we found a 6% increase per month of meniscal tears with delay to surgery. And it's not just the number of tears, it's also the type of tears. And so we found over 12 weeks, the irreparable tear pattern increased dramatically. And so it's number of tears and type of tears that we're having as well. The Norwegian group, so Lars Engebretsen, Håvard Moxnes, this is his PhD thesis. I was actually on his PhD panel, have tried to identify copers in kids, so children who can tear their ACL but not need surgery and can remain active. And they have a number of prospective cohort studies. If we look at the data, though, many of them don't achieve their pre-injury level of activity, 65%. In the second study, 40% went from level 1 high activity to a lower level, level 2. And then in this other study where you looked at the initial MRI and a follow-up MRI, almost 20% went on to develop further meniscal tearing. And so there may be copers in children, but they're hard to identify. And again, these kids are at risk. We can look at the data and we can look at our anecdotal experience. This is what I typically see. This is a prepubescent child with an ACL tear, no meniscal or chondral injuries. This is a physeal sparing reconstruction with IT band, and they go on to do fairly well. Another, tear that we're treating at about 4 to 6 weeks after injury, and they do have a meniscal tear, but it's a repairable pattern, and we can reconstruct the ACL even in these young children, and this patient went on to do well. This is what we typically see when a child's been managed non-operatively, and now this was 12 months later, comes in and they have this irreparable meniscal tear pattern, full thickness chondral defect. So we can reconstruct the ACL, but obviously you're much more concerned about the long-term health of this knee. So I would say that the pendulum has switched from non-operative to operative treatment for the initial management of children. And this is reflected in the survey data. So if we look, this was a survey we did in 2002, where we're looking at surgical treatment. The 8-year-old is on the left and a 13-year-old scenario is on the right. 2002 is in orange. And you can see that surgical treatment only 16%. And then in 2019, 60% for the 8-year-old, and then 34% and 80%. And so I think, again, that pendulum is shifted and it's reflected in our survey data of practice patterns as well. So if I've said now that non-operative treatment has a poor prognosis, that brings us to what are our surgical treatment options. And the menu is shown here. We have extra-articular alone, physeal sparing procedures that don't go through the growth plates, partial transphyseal procedures that go through the proximal tibial physis, but avoid the distal femoral physis, and then techniques that go through both the distal femoral and the proximal tibial physis. If we look at that historical literature briefly, we find that extra-articular alone has poor prognosis, like it did in adults. Primary repair also has poor results, as it does in adults historically. This is the BEAR technique, so the bridge enhanced ACL repair, which is pioneered by my colleague Martha Murray at Boston Children's Hospital. And this is a biologic scaffold, so primary repair with a biologic scaffold that's now been FDA approved in adults, and we're starting to use in adolescent patients as well. So this may have, this is different than traditional primary repair and may have some benefit in these patients. Physeal sparing techniques have been described. Brief described this technique using the hamstrings that goes over the front on the tibia and over the top on the tibia. Professor Gazzanti from Rome described this technique with an epiphyseal tunnel in the tibia to an epiphyseal staple on the femur. Alan Anderson described an epiphyseal technique, so you're drilling tunnels within the epiphysis, not crossing the physis, using a soft tissue graft. And Dr. Michele and I have described this technique using the iliotibial band, both extra-articular and intra-articular. Transphyseal techniques have been described, begin going through the proximal tibial physis, over the top on the femur, or through an epiphyseal tunnel on the femur, and then a variety of transphyseal techniques with different grafts and different fixation. The problem, though, when you look at the literature, is that these are largely small series that are retrospective, so level 4 level of evidence, and they don't chronicle well the amount of growth remaining. So many of these studies have chronologic age, not skeletal or physiologic stage, And when you look closely, many of these patients are older Tanner 4 patients who don't have that much growth remaining. Preoperative alignment, x-rays are not typically done routinely, and postoperatively routinely. So these are some of the problems with the literature. I think it's very important to think beyond chronological age. And so these boys are all the same chronological age, but this boy is obviously in a very different physiologic stage than this boy. These girls are the same chronological age, but this girl's in a different physiological stage than this girl. And as you get into more multi-ethnic and diverse groups, this was our son's AAU basketball team, you're going to have the same chronologic age, but children in very different physiologic stages. So how do we get past chronologic age? We can get to skeletal age using the Grilic and Pyle atlas in the hand and wrist. There are other atlases for the knee, et cetera. We get to physiological age using the Tanner and Whitehouse staging system. And so this is, I think, important for us to do. We don't often have a hand x-ray when we see the patient. So we've looked at knee x-rays to try to look at their physiological stage based on the status of the tibial tubercle. And we have stage 1, where the tibial tubercle is all cartilage. Stage 2, where we have a apophysis, so a bony apophysis. Stage 3, where that apophysis fuses with the epiphysis, but the physis is open. And stage 4, where that proximal tibial physis is closed. And stage 1 and 2 are really prepubescent patients, and stage 3 are pubescent patients. And so this may be useful in our management and understanding of how much growth they have left. Why is that important? Well, we know the majority of growth in the lower extremity is coming. Oops. Is this on now? Sorry. All right. Okay. So I'll put this back in here. So it looks like the microphone's warmed up. So why is it important? It's important because the majority of the growth is coming from the distal femoral and the proximal tibial physes. And this is very dynamic. So we know we have coronal and rotational plane alignment changes during growth and development. Obviously, that's very important in terms of the risk of a growth disturbance. And so in animal models of transphyseal reconstruction in rabbits and dogs, the results have been mixed with some growth disturbances, other cases where there aren't growth disturbances. Historically, there had been 2 cases in the literature until we published this series in 2002, which had 15 additional cases of growth disturbance, 8 cases of valgus with a growth disturbance, 2 cases of valgus without a growth disturbance, 2 cases of leg length discrepancy, and 1 was an overgrowth, and 3 cases of recurvatum of the knee with an injury to the tibial tubercle apophysis. When we looked at these cases for pearls, we found some obvious things like avoiding hardware and bone plugs across the physes, try to minimize the size of the tunnels, be careful in the over-the-top position because the perichondrial ring is very close, and then consider modifying your technique based on how much growth the patients have remaining. These are just some illustrative cases that we've seen. This was a 14-year-old male with normal alignment, had a transphyseal reconstruction done elsewhere with allograft. You can see the normal alignment sort of preoperatively and postoperatively. And then this went on at 10 months postoperatively to fail with a valgus deformity of the femur. So this was treated with revision reconstruction with guided growth. This was a 10-year-old male that was treated with a transphyseal technique done elsewhere and now presents to us at age 16 with graft fail and substantial valgus deformity of the distal femur. And you can see this growth disturbance here in the distal femur, open proximal tibial physis. And so this was treated with staged osteotomies and revision reconstruction. This was a case from HSS that they reported showing this proximal tibial apophyseal deformity and recurvatum deformity that needed a tailor spatial frame. We've looked at this with MRI after transphyseal reconstruction, and we found that small focal bony bridges were very common, but often didn't result in growth disturbance because they were less than the 7% threshold we think it requires to result in a growth disturbance. So these things certainly can happen. Even in all epiphyseal reconstruction, so there have been case reports of growth disturbance and actually overgrowth of the femur from stimulating the physis by drilling within the epiphysis. So what's our treatment algorithm? And that's shown here. Probably the largest group that we see are adolescents. So they are skeletally immature, but adolescents with growth remaining. These are typically Tanner 3 or 4 patients, males sort of 13 to 16, females 12 to 14. And again, probably the largest group that we see in our ACL reconstruction. And in these patients, we typically do a transphyseal reconstruction. So it's anatomic with a soft tissue graft, hamstrings or quad tendon, and fixation away from the growth plates. We published on this initially in 2007 in 61 knees. Average patient age was 14.7 with good functional results and return to sports. Since 2007, we've modified how we drill the femoral tunnel to be more anatomic. So typically through anteromedial portal drilling or outside in portal drilling. As we get that more anatomic tunnel, we have to be careful about the obliquity of that tunnel, because as it gets more and more oblique, it'll be a larger cross section across the physis. And in some cases, it may make sense to make an epiphyseal tunnel. But when we make an epiphyseal tunnel, we have this killer turn of the graft, and it's not clear what the significance of that is. I think the more vexing situation, though, is the prepubescent child. And this is something we see now very frequently. So these are younger children, have not hit puberty, so Tanner 1 or 2, often males 12 and younger, females 11 and younger. And again, non-surgical treatment is not going to have good success in these patients. So what are the options? Transphyseal reconstruction's been described, but if there's a growth disturbance, as you saw in the second case of growth disturbance, it can be very substantial. Epiphyseal reconstruction's been described by Alan Anderson, but we again have this killer turn, and we can stimulate overgrowth. We tend to use this variation of the McIntosh procedure, where we take an IT band graft, leave it attached, bring it in the knee in the over-the-top position, and make an epiphyseal groove on the tibia. This is that technique. So you're looking at the lateral knee, the iliotibial band, and we leave it intact distally towards Gertie's tubercle. We're bringing it through the knee in the over-the-top position. We make a groove in the tibial tubercle, in the proximal tibial epiphysis, and we bring it under the intermeniscal ligament. This is the intra-articular component, and then we fix it to the periosteum of the tibia. This is a relook arthroscopy at 2 years for a kneecap dislocation, and you can see the appearance of the intra-articular component, and this is the MRI of that patient showing the position of the graft. So it's more posterior on the femur because it's in the over-the-top position, but we can get fairly anatomic on the tibia. We published our results in 2005 in JBJS in 44 patients. Average age was 10.3, and we had good functional outcome, return to sports without growth disturbance. We published a larger series in 2008 that we reviewed at Journal Club last night, which was 240 knees, 11 years was the average age. 50% of these patients had concomitant injuries. They had good functional results. Revision rate was low, 7%. Interestingly, 10% went on to tear their contralateral ACL, low rates of subsequent meniscal injury, good functional outcomes in the patient-reported outcome measures, and high rates of return to sports without growth disturbance. And so we think that this is a good technique in the prepubescent patients. Actually, Brian Feely from here studied these different techniques biomechanically and found that the IT band intra-articular, extra-articular was the closest to restoring biomechanical integrity. And that may be because of the lateral extra-articular component. And that has been an area of great interest recently, adding a lateral extra-articular tenodesis to intra-articular ACL reconstruction. And that's included in this reconstruction technique. We've looked at this technique in terms of post-op recovery and biomechanics in terms of their strength, hop tests, and balance tests. And they showed less deficits than our hamstring patients and our patellar tendon patients. We've looked at it with motion analysis. And again, they show less deficits. And that's probably because we're harvesting the IT band. We're not harvesting the extensor muscle group with the patellar tendon or quad tendon, or the hamstring muscle group with our hamstring reconstruction. So some thoughts here in conclusion. The pediatricians will say the child's not a little adult. And I think in pediatric sports medicine, we're trying to say that the child athlete's not a little adult athlete. They differ physiologically, anatomically, psychosocially, biologically. It's important to know the patient's growth remaining. So think past chronological age. It's certainly a shared decision-making process. And so non-operative treatment avoids surgery, but has risks of meniscal chondral injury. Surgical treatment has risks of growth disturbance. We need to understand the pediatric knee anatomy, the distal femoral physis, and the over-the-top position. Be careful of the tibial tubercle apophysis, avoiding hardware and bone plugs across the growth plate, and think about modifying our technique based on how much growth the patient has remaining. So transphyseal techniques in adolescents and physeal sparing techniques in prepubescence. I think this is actually a really great area, an opportunity for prevention. And this is a histogram of ACL reconstructions done by folks taking the ABOS exam. And we can see that the majority of ACL reconstructions in this country are actually in teenagers. And you see that in international data as well. And so if we want to try to prevent these injuries, we should be working on teenagers and even prepubescent children. So prevention, we know, works through educational programs like Stop Sports Injuries, which we started in AOSSM, and in interventional programs like the FIFA 11. This is our McKaylee Center for Sports Injury Prevention. We have 2 centers in Boston now where we work on injury prevention, including ACL injury prevention. And we certainly need more data, and this is where we're trying to get to PLUTO. So PLUTO is the Pediatric ACL multi-center prospective cohort study, understanding of treatment options. So this is a study that had been planned since 2005. We started enrolling patients from 2016 to 2020, and now we're following those patients. It follows in the prospective cohort tradition in sports medicine of MOON for primary ACL and MARS for revision ACL. As part of this study, we had to develop and validate appropriate outcome instruments in kids. And so the IKDC was the most used outcome instrument, but hadn't been developed or validated in children. So we looked at cognitive interviews for comprehension of the adult IKDC. We modified it to the PD IKDC. We then had to validate it and develop normative data, as that was a primary outcome instrument. In the PLUTO study, we have a flow chart with what studies and forms are done at each phase in the study protocol. We have really 2 groups, the prepubescent groups defined by skeletal age and pubertal status. And then we have different treatments. We've got non-operative treatment, transphyseal reconstruction with different grafts, partial physeal reconstruction, and then the IT band physeal sparing and the epiphyseal IT band sparing reconstructions. As part of the study, we have to do a lot of standardization. So we had to standardize our imaging, how we define leg length discrepancy, alignment, pubescence, surgical techniques, what non-operative treatment is, how we're bracing after surgery and return to sports, rehab, criterion for return to sports, and then how we follow and measure complications. This is a study cohort, and we have, you can see here, about 770 patients, and they now have all minimum 2-year follow-up, and we hope to follow these patients at least a 10-year follow-up. As part of our research agenda, we had systematic reviews, which we published on growth, early, delayed, and non-operative treatment and outcomes assessment. We've published our data now on baseline epidemiology in meniscal chondral injury. We're now gathering our minimum 2-year outcome data, and then we have a large number of planned studies based on our data. And now we're adding another cohort, PLUTO 2, which includes transphyseal soft tissue reconstruction with lateral extra-articular tenodesis because that's becoming very common. So if we just look at some preliminary PLUTO data, we have about 750 patients, about 62% of them are male in this study. Average age was 12.3, mean time to surgery 53 days. Over 50% had concomitant meniscal tears, and we had some patients with chondral injuries as well. We found that meniscal tears weren't associated directly with time to surgery as a continuous variable. But when we broke it down to delay over 60 days and under 60 days, we found that a greater delay from 60 days was associated 1.5 odds ratio to have a meniscal tear. Cartilage injury, similar, was associated with patients' bone age, meniscal tears, and time to surgery. A bone age over 13 years, 7 times more likely to have a cartilage injury, and a delay of over 90 days, 3 times more likely to have cartilage injuries at the time of surgery. These are our surgical techniques. This is a little hard to read, but the patient's age is at the bottom in terms of skeletal age. Transphyseal is an orange, and so you can see in the adolescent patients, we're predominantly doing transphyseal reconstruction, and in the younger patients, we're doing physeal sparing techniques like all epiphyseal, physeal sparing with IT band. In this 11, 12, 13 age group, that's really our sort of transition age where patients are having all different types of reconstructions, and that's an interesting age to study. We found that under bone age 13, physeal sparing techniques, IT band, all epiphyseal were most common. Over 13, transphyseal were most common. And then now looking at some of our preliminary data at the minimum 2-year follow-up, we found that our re-tear rate is actually fairly low in the younger children, the prepubescent children. And so if we look at the different techniques, the all epiphyseal techniques and partial transphyseal techniques, IT band techniques, these are predominantly in the under 13-year-old age group. Our failure rates are up to 5%. We're at 2 years, whereas our transphyseal techniques that are being done in our adolescent patients have a much higher failure rate. You can see 10% with hamstring and 8% with quadriceps tendon. Our outcome score, so this is the change in PD IKDC outcome score from baseline to follow-up, are fairly similar across the different techniques. And then we can look at the PD IKDC and re-tears by their Tanner stages. And so the younger patients, Tanner 1 and 2, their failure rates are much lower, 6%, than the older Tanner stages, 3, 4, and 5. But their increases in their baseline follow-up PD-IKDCs are very similar. And so this study, the PLUTO, really takes an investigative team. So we have primary investigators at 10 different sites, and then we have research coordinators at this 10 different sites. We have monthly research calls. We have funding from a variety of sources, including research grants and philanthropic grants as well. And the goal here, this was actually a cartoon that I saw in the 90s when I was a resident that had a big impact on me, which is let's just start cutting and see what happens. And I feel like we often do this in medicine and in orthopedics. And by trying to get better data in a prospective way and in a cohort way, multi-centers with comparative groups, hopefully we'll have better data and we can get away from this cartoon. So thank you again for the opportunity to be here. It's really a treat for me, and thank you for letting me share my thoughts on pediatric ACL injuries. Thanks again.
Thank you, Dr. Kocher. That was outstanding. Work has just been amazing. Forward to seeing more of it as the PLUTO results come out. I think we have some time for questions. Open it up. Start with Dr. Marks. Thank you, Dr. Kocher. Such an excellent talk about your body of work. One of the questions I had was looking at that prepubescent age that you said those patients tend to do a bit better. My guess, and just based off of my residency and thoughts about kids and adults, is that it's not just like activity levels, something about the physiology of that prepubescent age can predispose them to improvements or just better healing. Is there any evidence in like either the basic science literature or imaging studies like that is the case, that graft maturation is different in those?
Yeah, it's a really interesting question, Alex, because I think that there's so many differences between the prepubescent and the adolescent, and then you go to the adult patient. I mean, they're certainly very active, right? Like they're just running around and they're doing stuff at recess and they're doing sports. I think maybe the organized sports games showcases, select teams, that becomes more common in adolescents. So maybe their exposure risk goes up in a higher competitive setting when they're older. I think the older adolescents are also bigger, so they have more body mass. Their limbs are longer, so they may have greater moment arms. So there's some things going on there anatomically as well. There may be some psychosocial differences. So our prepubescent kids that get injured, when we've studied them psychologically in terms of readiness to return to sports, they just are ready to go. They have a low fear of re-injury, and maybe that's a good thing or a bad thing. But our adolescent patients have a higher fear for re-injury. And there's some data to suggest that fear of re-injury puts you in a certain position that may make you more likely to be re-injured. But I think the biology, what you're asking about, is very different. I think they heal more quickly. We see that with fractures and sort of all things in children. And then we've been studying, MRIs of kids after ACL prepubescent kids 1 year after ACL reconstruction, and then looking like 6 to 8 years after ACL reconstruction, because the knee's getting bigger. And if we're putting in this graft, what happens to the graft? It either is going to tear or it gets bigger as the knee gets bigger. And we have found that it grows, so it gets longer and it gets wider as the knee grows. And as the knee grows, maybe if there's some laxity, that tightens up over time. Maybe it's more biologic in terms of the graft is really just a scaffold, and then they're putting their cells into it. And so maybe they have more biological activity. So those are some of the hypotheses that we have.
Hey, can you help me with something I've always struggled with? When we have a growth disturbance in a physis, we cut it out and we put soft tissue in place, fat, whatever, usually. But I think a hamstring graft would be great soft tissue. And we say up to, so nobody really believes 50%, but we say 20%. Yet, if you put a graft across the physis when you're replacing the ACL, that's more than 7%, you start worrying about growth. What's going on there?
Yeah, it's a really good question. So originally we had in adult sports medicine, we had to say you can't really put bone blocks across the growth plates. That's the Femister technique. That's kind of what we did to get a growth arrest back in the day. And then soft tissue grafts across the physis appears to be safe because it's a relatively small threshold in terms of the cross-sectional alignment. I think some of the issues is that fixation devices could be across the physis. There may be an issue with drilling across the physis, and so you may get some thermal injury of the physis as well. And then there may actually just be a tenodesis effect, like if the ACL is going across the lateral femoral condyle and it's under tension, could there be a tenodesis of that effect that leads to valgus as well? I think the bigger issue, like we just saw a case last week of an ACL reconstruction in an adolescent that was drilled with an outside-in technique using a flip cutter, very horizontal, and that just essentially went right across the physis. And so that's a large growth disturbance. And so as we've changed that technique, in a way, transtibial drilling of the femoral tunnel was pretty good for the physis because it was very vertical. And so as we get more anatomic and more lateral, we're taking out a larger oblique cross-section of the physis. So that's a problem I can maybe help you with. The problem I can't help you with is the thing that's bothered you for a long time. So Muhammad has always been bothered by pediatric orthopedics, and our society, POSNA, is a Pediatric Orthopedic Society of North America, and I was just president last year, and we got a lot done, but I couldn't change the name because the diphthong issue has always bothered Muhammad because pediatric orthopedics is PAED, but orthopedics is PED. So it's driven him crazy, and I couldn't change it. So sorry. Yes.
Dr. Kocher, thanks. I'm Sam, one of the sports fellows. I had 2 questions for you. I just was curious if you could speak to why you thought in that prepubescent group there was higher failure rates with the transphyseal technique in the data you showed, whether that is due to malalignment that had to be fixed, or if there's something about a transphyseal technique in itself in that age group that leads to failure.
Yeah, I don't know. I don't think we really know that yet. We haven't dove into that. And so I would say kind of to be determined, and I'm not sure if that's actually a significant effect yet. I think, there have been transphyseal in the prepubescent patient population. There have been case series from Leo Pazuski in Australia and from George Paletta showing good functional outcomes with lower failure rates. I think the problem in that group is that growth disturbance is uncommon, but when it happens, it's so significant, right? Like the prepubescent patient that had that really bad valgus deformity or that recurvatum deformity. And so that it may not be, for a complication, the issues are what's the incidence of the complication, but also what's the significance of the complication. And, it may not be very common to have a growth disturbance, but the significance of it can be very.
And then the second question was, it's early on, but what is your thoughts on the role of Dr. Murray's bridge enhanced repair in the adolescent?
Yeah, I think it's going to be really interesting to follow. That's the group that has the largest failure rate. And so in the Bear studies, the adolescent patients are sort of, I think now down to 14, but 14 to 18-year-old have a high failure rate, almost 30%, and it may approach 40% because they're very active. And the older patients who are lower demand do better. So we'll have to see how that kind of plays out. I think if you do a Bear in an adolescent patient and they go on to fail, the revision is very simple. It's like a primary ACL reconstruction. So maybe it's not, such a bad thing. On the other hand, if you had like a, high level adolescent athlete who wanted to play in college or beyond, to do a reconstruction that has a higher failure rate, may not be acceptable to that kid and to that family. So I think there's going to be some shared decision making at the end.
Dr. Kocher, thanks again for coming to talk. My question is about, as we're doing more pediatric and adolescent ACL reconstructions, inevitably there's going to be more failures over time. And then I don't know if this comes across as a problem, but the management of tunnels, at least in the adult patient, you worry about tunnel widening, having to bone graft a tunnel and think about those things in revision settings. Is that how much of a consideration is that for you as you're seeing these younger adolescent patients come in who have failures, who have soft tissue grafts, transphyseal drilling, those sorts of issues? Yeah,
it's a really good question. And I think it's really sort of a case-by-case basis. So if you have like a prepubescent patient that had an all epiphyseal reconstruction, we can do the IT band technique, pretty easily, and it's not going to affect us. If they had an IT band technique and it failed and they're still prepubescent, we can do an epiphyseal technique and it's pretty easy. I think if they've had a transphyseal technique, open growth plates, now they've failed, they have tunnel widening, but their growth plates are closed, then it's pretty easy to bone graft the tunnels and do a revision. I think the issue will become the adolescent with open growth plates who has a transphyseal reconstruction, fails and has some tunnel widening, and that tunnel widening is across the growth plate. How do you manage that? And that can be challenging. We're often doing actually an IT band technique even in those older adolescents, so we don't have to do a tunnel in the femur, and we can do an epiphyseal groove in the tibia. But I think, again, that's on a case-by-case basis. Many of those patients will fail and don't have tunnel widening, so you can do like a revision. And if they're older with BTB, or if they're younger with quad tendon, if they were hamstring to begin with, and you can make new tunnels, which seems to be.
And can I go back to the growth plate? Actually, last year, I discovered just serendipitously, there's a radiologist in Columbia who's doing this DTI, diffusion tensor imaging, which is an MRI sequence, which is like a functional MRI of the growth plate. And his data is pretty neat. So they sort of look at the columnar pattern of the cells, and they can predict the growth remaining. So I wonder, like for your MRIs, you're getting the MRs anyway, just a couple of different sequences, and you can actually predict, if you believe his data, on the functional sort of activity of the physis. So this whole thing about skeletal age, Tanner staging may actually get a little defunct if you can actually look at the cells and the function.
Yeah, I'd love to follow up with you on that, Sanjeev, because I think that has a lot of potential, particularly if it's not like a specialized MRI, like a 5T or 8T magnet or something like that. And so if it's a regular magnet, 1.5 or 3, and it's just a different sequence, that could be because the patients are getting knee MRIs anyway. And it's, as you know, it's really challenging, to get a hand X-ray Grulich and Pyle atlas, and you're using data on, white children from Wisconsin in the 1940s to now sort of predict growth in a multiracial society that's very different. And so, I think that those data are not, I think it's really important to think beyond chronologic age, but I don't necessarily think that the Grulich and Pyle atlas has the answer.
You're following up on that and wondering about why transphyseal can cause injury. You think there's a component of physeal injury at the time of ACL?
Yeah,
that's maybe just chasing. You're maybe chasing a phantom. You think it's the technique. You think it's the, the obliquity of it. You think you got to, but maybe just that some patients injure their growth.
Yeah, it's not common. I mean, all these patients get MRIs of the knee, and it's not common to see a physeal injury. Like when you get a Salter 1 fracture of the distal femur, normal X-ray, you get an MRI, you can see that edema around the physis, and you suspect there is a physeal injury. We don't really see that, so much when we get the MRIs, but there may be something, kind of more subtle happening to the physis for sure. And especially the tibial tubercle apophysis, which is very sensitive. It has been fascinating to get pre-op hip to ankle X-rays on all of these patients, and I think it's really important to do now when you're treating these patients, because we do see a fair number of kids who have a 1 centimeter leg side-to-side difference in their leg lengths. We see a fair number of kids, who their coronal plane alignment is not the same on both knees. And so now if you see that post-op and you're blaming the surgery, you don't know what was there pre-op. And it's much more than I would have thought. I don't know, maybe the limb lengthening and growth data are in pediatric orthopedics is more clear, but it's a really rich data set of 750 patients who've got pre-op hip to ankle alignment X-rays. I mean, there are a fair number of differences in their leg lengths and their angular.
Dr. Kocher, what's your current preference for graft, especially soft tissue? Like, have you switched to more quad tendon? Are you hamstring dominant? Or
Yeah, I think, at our institution for soft tissue in adolescents, we have 7 surgeons, and about half do hamstrings, about half do quad tendons. We're not seeing a big difference between quad tendon and hamstring in this study. Other studies in adults have shown lower failure rates with quad tendon. So I definitely think quad tendons being used more and more frequently. I think the other change that's really happening is adding an LET. So now in the adolescent patient population with transphyseal hamstrings, when I do that, I'm almost always adding an LET. And that's going to be part of this PLUTO 2, where we're looking at that transphyseal soft tissue with an LET to compare to the transphyseal soft tissue without an LET. So I think that'll be interesting data. Yes.
for those patients that you do kind of extra-articular, intra-articular IT band technique, have you ever seen, like, in the setting of revision, like, can you still use that IT band if you're to do an LET, or is it fail kind of like?
Yeah, I just had a patient the other day that we did this in, and I don't think you can reuse the LET because you take the IT band, because you take a fairly wide portion of the IT band because it's so flat to get volume when you do this reconstruction. And so in that setting, we actually did an ALL reconstruction with allograft instead of a LET with IT band. Good question.
Early in my career, I was in ACL study group, and at that point in time, it was Werner Mueller and John Fagan, and had started this group of international surgeons. And the main focus of concern and reason for gathering was to measure stability in a knee.